Hello and welcome to another edition of Health Solutions with Shawn and Janet Needham, where Team Needham discusses everything healthcare. I'm your host, Shawn Needham, along with my wonderful wife, Janet, and we are super excited to be streaming live from the Moses Lake Professional Pharmacy Podcast Studio, and even more excited to have Caleb Dotson on our program today. He is a physical therapist out of Spokane, Washington, and he is going to be talking about how a physical therapist can relieve pain and how he has some interesting ways to do that. So, Caleb, welcome to our show.
Thanks for having me.
All right. Well, tell us a little bit about your history and how you got to be on our show.
All righty. So I did undergrad at WSU, Washington State University, and then got my doctorate at Eastern in 2015 and practiced in PT for several years, a little while in Southern Oregon, and then moved back up to Spokane and consistently had patients who weren't getting better. I had a lot that did, but I had that 20% that just weren't getting better. And then started my own PT practice during COVID and learned what's called the fascial distortion model, which has allowed me to provide a great out-of-network service. And then met you guys at Healing Local here in Spokane, heard about what you guys were doing, read your book, and asked if I could be a part of your podcast.
Awesome. Well, we appreciate you being on. So tell us a little bit about this special modality that you have to help relieve pain.
All right, so it's one of the main things I use. I also use like primitive reflex integration, very little. I use some whole body, like how a person compensates for things. But the bulk of what I do, the meat and potatoes, if you will, is called the fascial distortion model. The fascial distortion model is an anatomical perspective in which most injury and disease are considered to be comprised of one or more of 6 specific distortions of the body's connective tissue. One of the main tenets for it also is when a person has pain, regardless of their language, culture, etc., how they describe it and how they show it with their hands is going to be the same. So if a person comes to me and they say they have shoulder pain and they point with one finger, that's a particular distortion, versus multiple fingers, that's a different distortion. And I'm going to treat those slightly differently. Or if they're drawing a line with the tip of a finger, that's a particular distortion. Holding is a particular one. Hovering over, those are all going to be different distortions that I can treat differently. And because I'm going after the fascia and more of the tissue that's causing that symptom, I can get much quicker results than what I used to do before learning the fascial distortion model.
That's awesome. So I can tell you when I learned about the fascia and how it interconnects everything, and I say that word loosely, everything, but I was at a pain conference one time, and Dr. Hal Blackman, I think he was based out of Ohio, and this conference was in Canada, and he said, "Is there anybody in the audience that has any pain?" And I'm like, "Sure," and typical is, as you know, Caleb, is shoulder pain, in the back from using the mouse all day, driving, all that kind of stuff, right? Anyway, this guy was good, and he said, so I'm walking up there, and he goes, I didn't tell him where the pain was. And he's like, "You got right shoulder pain." And I'm like, "Yeah, you're right." And then he palpated it, and right away he hit it like that. He hit it that fast. And then he pushed it harder, and he goes, "You should be numb in your little finger right now." And I'm like, "You're right." And then he pushed it harder. "You should start feeling tingling in your toes now." And it just proved to me that the fascia is linked all the way from your shoulder to your feet. So if you want to explain more about that, I would appreciate it.
Yeah, so what he was doing there was more so focusing, and sorry, my gimbal decided to be weird. He was focusing on the nerves specifically. And so same idea where you can mess with a person's nerves. And that's the other thing I focus on is the nerves. The fascia, I would say, is more than just everywhere. It's a part of everything. It makes me think of that quote from Star Wars: A New Hope when he's talking about the Force. It surrounds us, it penetrates, it binds us together. One of the books that I use when working with patients is not an English book. It's primarily a picture book because the fascial distortion model transcends language. But in here, this graphic shows how before you even get to the first layer of muscle, you've got all these layers of fascia. And then this is a single muscle cell. And even the lattice work that forms the structure for cells is fascia. So it's beyond everywhere. And when you say that, I can't remember the exact phrase when you're talking about it being everywhere. It really is everywhere. It's throughout and around all of our cells, all of our organs, etc.
So what do you do with this fascia? Do you massage it? What do you do as a physical therapist to make the pain go away?
So a few different things. One of the people that made the fascia more famous, I can't remember his name right now, but he's got Anatomy Trains as one of his books, and he talks about these different pathways that are throughout the body. And so, for example, if I'm pulling on my shirt by my left hip, and you can see how even up in the collar that's moving. So one of the things that I do outside of just focusing on where the fascia is distorted is I also look at how the fascia is mapped around. So a case in point with that, I had a patient who had a right ankle pain that had been there for 20 some years. And this was like 3 Octobers ago while I was still in an in-network clinic. And I recognized that she had a nerve issue going on. When we tested a certain muscle strength, she had no strength there. When she did a heel raise, she'd say, hey, it feels like my ankle's going to implode. I recognized that was because of a nerve agitation in what's called the lumbar plexus. So nerves coming out of the spine near the pelvis. That nerve agitation was because of a shift in her pelvis in the low back area, abdominal area. That shift in the abdominal area of that fascia was because her right C6 nerve root was agitated. And then she had a big chunky sweater on. I said, hey, is there any chance you've got scars in your right arm? And sure enough, she did. And so I could go to one of those scars, relieve some of the tension there that was agitating one of her nerves. That nerve no longer being agitated meant the muscles from that nerve was innervating were no longer tight, offloaded the shift in her lower abdominal fascia. And when we rechecked, she could do a heel raise with no pain and was 5 out of 5 strength with those muscles that had previously been weak. So that's some of how I can take the fascial distortion model as well as just a full understanding of anatomy and get phenomenal results.
So how quick are those results? Is it immediate, or is it like you have to do it multiple times? Does it just depend on the injury or the situation?
Yeah, it really depends on what we're talking about. So that one was, she had 20 some years of issues, so she had to go after some of that with what I call resets. However, if you check my Instagram last month or the month before, a person paid for me to come down to Southern Oregon and work with a bunch of college athletes. And most of them had shin splints, etc. And you can see in those videos, sometimes 1 minute of treatment and a person's symptom free.
Wow, that's amazing. It's also a reminder too. Now, just correct me if I'm wrong, but basically this gal's pain was getting referred from scar tissue from many years ago. Is that what you were saying?
Yeah, so the scar tissue was agitating a nerve, and then the referral was traveling along that nerve. So that our nerves have afferent and efferent. Afferent, it's acquiring information, efferent, it's sending information. And so the scar was agitating a nerve that was going up the nerve branch, and then from there it was traveling back down that same nerve level.
So it's also a reminder that you really have to talk and listen to your patients to get to the root of where the injury came from. A reminder, when I was at that same conference, Dr. Blattman was talking about how somebody had severe neck pain. And it really originated when they started doing a history. They'd had a car wreck like 20 years before and they broke their foot. And it really originated all that from their foot. So once they dealt with those kind of issues, then the neck pain went away. Just a reminder that, you know, it might not be the neck that's really causing the problem. It might be something else.
Yeah, and you did a podcast episode, I think it was 105. I can't remember the name of the person that you had on there. But it was when you guys were talking about the PCOS, I think. You talked about how, as a health provider, a true like artist in our work, we can't just look at the lab test or the special test, et cetera. We have to look at the body as a whole, the individual as a whole. And that's where, when it comes to musculoskeletal, a physical therapist should be the musculoskeletal expert. We should be able to look at and extrapolate if here's where the issue is. For example, osteoarthritis in the knee. Notice I said osteoarthritis, not some of the other arthritises.
Right.
But in my mind, that's because of a change in tensegrity. The joint isn't loading the way it's supposed to, and that led to the osteoarthritis. So when I see these diagnoses that are more medical diagnoses, my next question is, but why? Why did that happen in the first place? And can I work back and kind of figure that out? It's like when your light goes on your dashboard to say that you have low tire pressure. What some healthcare providers would do, assuming the dashboard light is pain, is they'll just stick tape over it. In my mind, oftentimes that's what pain medication is we're just sticking some tape over that light. the next step though is, okay, that light is on, but why? It's on because your tire pressure is low. And then you ask yourself, why is the tire pressure low? Is it because it's sub-zero outside and so the air is just decreased? Or is it because you have a hole in the tire? And where I used to be as a physical therapist, and where, in my opinion, a lot of PTs are aiming towards, because our healthcare system is set up to aim towards this, is, okay, let's put air in the tire. Let's get to where they're not in pain, where they can live their functional life. And that's where it stops. That's where the standard of care stops. But myself, and not having to deal with the insurance side of things and working for my patient instead of insurance, I get to say, okay, but why is that hole there in the first place? Yeah. Is it because the tires need rotated? Is it because your lifestyle is akin to driving over a road with nails all the time, and we've got to change some lifestyle stuff? So that's where I try to focus, and that's one of the ways that I'm able to provide the kind of education that you guys are so big on providing with your podcast.
Well, thank you for the kind words. And I love the analogy of the car light and the air pressure in the tires. And I love what you said about the insurance-based healthcare system too. In the insurance-based healthcare system, the most financially rewarding way would be to keep airing up that tire every month. Just, it doesn't matter why it's leaking. Let's just keep getting you in here and airing up that tire instead of fixing the tire. Because insurance companies reward people by keeping them in the office more and more, not really getting them healthy. So in reality, most physical therapists or most healthcare professionals, they have no incentive to keep you out of their office, right?
Yeah, and unfortunately, I experienced that the hard way here in Spokane, and it's part of why I started my practice. During COVID, I switched to be a fill-in PT, and so I worked in 8 clinics in a year, and I actually had owners who were saying, stop doing what you're doing because you're getting people better too quickly. And then I went, last October, I went to a big PT conference in Orlando and was chatting with some of the people there. And I love my one and dones. I love it when a person comes in, I do 1 or 2 sessions, and then they don't need me anymore until the next thing happens, because they're great referral sources. But a lot of the people I chatted with at that conference, they say, that's not our ideal client, which is fine. Like, work with the people, the post-op who needs a dozen sessions, maybe. But go ahead and do that. But that's not how I want to focus. And if at any point I'm focusing my treatment around that, then that, in my mind, that's not ethical, not okay. Which makes me really curious to see what's going to happen with electrical stim, because e-stim, or electrical stimulation, I think this year Medicare is no longer paying for it. And it used to be just a standard. You hook the patient up on electrical stim when they're done. They spend 15 minutes. The PT doesn't have to be there, and they get reimbursed $12 to $16 for that 15 minutes. And it was easy money. And now that Medicare is not paying for it, other insurance companies are going to drop it. And I would love to be a fly on the wall as the owners are chatting with their staff about why they're not encouraging their staff to do electrical stim anymore. And then to be a fly on the wall when the staff are then explaining that to their patients. Because I guarantee they're not going to say, well, insurance doesn't pay for it anymore, so we used to recommend it for every patient, and now we don't.
Right.
Well, that's a really good point, because ran into this even in our personal life. My youngest son had a compound fracture on his tibia, and the surgeon wanted him to start physical therapy. And our son, of course, growing up in our pharmacy and hearing us talk, asked his physician or his surgeon, how will my physical therapy be different than my grandmother's would be? And the surgeon told him there would be no difference. And my son said, well, then I'm going to look it up myself. Tell me what you want me to do, and I'm going to look this up myself. Because he knew that if, I'm different. An 18-year-old boy is different than an 80-year-old woman. Why are we putting them in the same category? And that's one problem with the insurance model, is that everybody's the same. Yep. And, obviously his recovery would be totally different than an 80-year-old. So why are we approaching it the same way? To me, it's like madness. It's like, that doesn't make any sense at all.
Well, I mean, again, it's like Caleb said, like Janet's alluded to, it's the insurance company dictating care.
Exactly.
And just like, for instance, and you can help me out with this, Caleb, because I don't know the details, but I've heard some ramblings, like after total knee surgery, I'm just using an example. After total knee surgery, Medicare will pay for like 6 physical therapy visits. So how many therapy visits do those total knee patients get? Whether they need them or not, they get 6, right?
I think it's a lot more than that for the total knee. It's really going to depend insurance to insurance. And I haven't been in the insurance realm for a couple of years.
Yeah, and good for you. But I guess what I'm getting at is chances are if they pay for 12 visits, 18 visits, they're going to get all 18 visits, right?
There are good PTs and bad PTs. There are good chiropractors and bad chiropractors. So like it depends. When I was in network, and that's part of why I was replaced in a couple of places where I was a fill-in PT, is because the owner wanted to get as much money per patient as possible. There are also employers I've worked with who are like, no, if you can get a one and done, that's awesome. Make sure you get a good review from them. And so you're going to see it differently, and that's going to depend on the individual that's providing the service, etc. I know there are plenty of PTs here in Spokane who, were your son to go work with them, they would provide very different care than what his grandma would get. Unfortunately, there are others who are going to apply the same principles to every single person, regardless of their health status.
And I guess our whole point is that's one of the reasons we stay away from insurance. You stay away from insurance because we don't want insurance companies dictating the care that we do with our patients.
For sure.
And that's one of the reasons we haven't billed insurance for 22 years in our pharmacy, because we don't want a third party in between us and the prescriber on what is best for the patient. Because let's face it, when it comes to drug therapy for most patients nowadays, if it's insurance based, the insurance companies tell them what to get, not the doctor. It's not based on the best drug for them. It's based on what drug is on that formulary for the insurance company.
Yep. Yeah, and that ties into why the fascial distortion model is not more popular, at least one of the reasons in my mind. When I'm doing my hands-on work, that reimburses, if insurance were paying for it, reimburses less than if a person's on a recumbent bike. So if insurance paying for what I do, I would make more money if I had the person on a stationary bike than if I'm using the skill set that allows me to have people who have shin splints and have 100% symptom relief in one session. So there's that
right
frustration.
And on the recumbent bike, I don't know physical therapy, but if you're doing this fascia model, you've got to physically touch them. On a recumbent bike, you can have 5 people on a recumbent bike making money for one physical therapist, right?
Well, there are laws on how many patients a PT can be working with and all that sort of stuff. But what will oftentimes happen and drives me bonkers when I was in network is the person will warm up on the bike, and then while they're doing that, the PT is finishing their notes on the computer. So they might be dialoguing with the patient, but really they're just finishing up their notes. And very, very rarely, when I was in network, very rarely would I have a person on a bike. And normally if I had a person on a bike, I was doing a test. So if they were a biker and they were getting towards the end of their rehab, I might have them on a stationary bike so we could test, hey, is your knee good during those ranges of motion? Are you able to get that cardiovascular difficulty up in an activity that's very functional for what you want to get back to? Versus every patient spends 10 minutes on a bike while I finish my chart notes.
Right. Well, I will tell you, I've known some physical therapists and worked with them throughout the years because of some of my biking industries when we talk about bikes. And I look at physical therapists, you already said it, but I look at physical therapists like pharmacists or drug experts. Physical therapists are any of the physical part of the body. So if you have any kind of physical pain, if you go to a general doctor, they're going to give you pain meds. But a physical therapist is going to, why does your knee hurt when you pedal your bike? Well, it's probably because your shoes aren't, you don't have the right shoes, right? Those are the things that physical therapists that address, and instead of just trying to mask it, putting the tape over the light of the car with medication. So we appreciate physical therapists.
And part of what you were saying there, my brother and his wife are medical doctors, and they had, and I might not be exactly right with the numbers, but they had twice the didactic musculoskeletal education of your typical GP. I think that was like either 3 or 6 hours, which is like one lab or one day of my doctorate. And so recognizing within the healthcare world that there are all of these experts, and then even within, for example, the realm of physical therapy, I refer out frequently because there are sub-experts within my profession even. So working with the organs, there's a PT in town that I'll refer out to work with the organs, because oftentimes those are one of those underlying things. And when a person's got 20 some years of issue, and then I take a look, oftentimes I'm able to say, I think this is coming from this particular area, and here's the expert to meet your specific needs. When they're done with that, if you still have stuff going on, please call me back.
Right. So Caleb, what is what is your passion, your favorite thing to treat? What passion do you have what do you have a passion for when treating?
So even in grad school, I took extra classes on the shoulder. The shoulder was one of those daunting things, and so I dove into it. And especially with the fascial distortion model, I love treating a lot of shoulder issues because it's misdiagnosed, because people don't have a fascial distortion model perspective. So one of my favorite cases, one of those one and dones, middle-aged individual who was trying to get back into playing tennis.
Who you calling middle-aged?
Like 50s.
Oh. At least you're not old. At least I'm not old.
Yeah. So he had severe shoulder pain and was on his way to was getting a referral to have imaging suspicion of a rotator cuff tear. And he came in and he showed me his pain with multiple fingers. And I have permission to share these, by the way. He showed his pain with multiple fingers. And I said, okay, I think you have what's called an HTP, or herniated trigger point. Herniated trigger point. If my hand is fascia, and this is something that should be contained inside fascia, there's your HTP. So if you have another layer of fascia and it's trying to slide, it can be pinching that, which can restrict your range of motion. And sure enough, he couldn't get his arm above 90 degrees. He had severe pain. I told him, okay, here are the rotator cuff tests that are going to be positive for a rotator cuff tear. You're going to have a mixed presentation. And sure enough, he did. I treated the HTPs he had in his shoulder, and I told him, hey, tomorrow I want you to go play tennis. And he's like, I don't think that's a good idea, Doc. I said, no, like, trust me, go play tennis tomorrow. If it doesn't go well, leave a nasty voicemail and I'll listen to it in front of you. Instead, the next day I got a text message. So one session, couldn't get his arm overhead. The next day I get a text message and he says, I served over 60 times, played some of the best tennis I've ever played. That pain has not come back. This was 2 years ago. I've since then worked with his wife. His son came in from out of town to work with me. So cases like that are my favorite, but the shoulder is one of those areas that I will frequently have better than standard care, or the typical like shin splints are just easy anymore. So those are also a fun one. I love the quick results. I love wowing people. And with shin splints with high school or college athletes, that's a fun one.
Yeah, they're painful. So yeah.
I mean, what a great story. So now I got to ask you a question.
Alrighty.
And you might not want to throw surgeons under the bus, orthopedic surgeons, but have you ever worked on somebody's shoulder? Do you think somebody that had the diagnosis that you gave with that tennis player, and I know you guys can't make diagnoses, but do you think anybody like that had surgery instead of doing what you did?
Here's the thing, though, and I will frequently, when I'm working with people, because most of my clients are either they have new onset and they just want to get better quick, or they've got 20-some years of issues. And so I frequently have people who come in and they say, wait a second, why did no one else do this before? And you can't judge a person for what they don't know. So surgeons are taught their wheelhouse and they do the best they can. And the patient presented in a way that would indicate surgery might be needed based on that medical model, that understanding of the body. But it wasn't until the early 2000s that fascia was really even taken into account. So if a person's working on an outdated understanding of anatomy, then you can't judge them for current understanding. You could critique them for not updating their understanding, but there's so much information out there that it can be difficult, especially when a healthcare provider isn't incentivized to learn a new understanding.
Right.
There are a lot of barriers to that. So yes, I guarantee you, there have been people who have only needed one session and they had surgery and all the things that come with that. There are also times when I send people to surgery. I've got a person who worked with her twice. She's getting surgery pretty soon. And I was saying, you need to have surgery for this. I don't care that I helped you so much. You need surgery because you have something that is structurally damaged. She had something that was torn to the point that I could help a lot with her symptoms, but her structure needed to be fixed.
Well, and it's also a reminder that there's a time and place for physical therapists, pharmacists, and surgeons. And what's important is that our job as healthcare professionals is to educate people as to when it's appropriate. Exactly. You talked early on in the podcast about medications just being a Band-Aid basically to cover up pain. And, in my personal opinion, I think when it comes to chronic pain, I don't think that there's ever a reason, unless you're in hospice, to be on chronic pain medications. if you have some kind of pain, get the problem fixed. Go to a physical therapist like yourself that knows how to address these issues, and maybe surgery is warranted. But being on pain medications, whether it's non-steroidal anti-inflammatories or whether it's opioids, I don't think either one are warranted long term.
Yeah, you're the medication expert, so I'll defer to your expertise with that.
Yeah. Well, Janet and I are kind of weird pharmacists. We're pharmacists that don't believe in drugs to treat most diseases. So,
Yep.
Janet, as we start winding this podcast up, what questions do you have for Caleb?
Well, Caleb, this is very enlightening. I love hearing what I'm hearing from you because I feel like most people don't get the experience that you are talking about. They get probably what my son was offered. So how would you navigate as a client how to find somebody that's good? Because, there's other areas out besides Spokane. What would you tell someone to look for a quality physical therapist?
That's a question that I wrestle with a lot. I get asked myself that a lot, and am working on trying to put together a book on how to find a quality healthcare provider, regardless of the subspecialty. And I think one of the biggest ones is find someone who's passionate about what they do. So during COVID, when I was working fill-in PT, the weeks that I would have 40 or 50 hours in the clinic, and I would be energized. I love what I do. Versus there are people that are burnt out and maybe healthcare is not right for them. So someone who's passionate about the work they do is one. Another one is someone who is not just meeting the standard for education. So as a physical therapist, I'm required to get like 32 hours of continuing education every 2 years in Washington. I think it's 24 in Oregon. This year I've got over 120. Last year I've got over 120. I'm just constantly trying to become the best healthcare provider that I can be. So passion, continuing to try and learn, and then also someone who will refer out, someone who will recognize, here's my area of expertise, and I'm going to stick in this area of expertise, and I'm constantly going to be aware of the other healthcare providers in my area who might fill in the gaps in my understanding. That team healthcare approach, I think, is also really important versus I'm a jack of all trades, master of none. In my opinion, less likely to get truly top line when you're possibly not with a person who is a specialist in what you need. Hopefully
I love that. Yeah, I love that. That's a great answer. So as we wind this podcast up, Caleb, what is the best place that somebody could get a hold of you if they had any questions?
So you can go on my website, oyhpt.com. It stands for ownyourhealthphysiotherapy.com. You can also find me at Instagram. I believe it's ownyourhealthpt. And you can email me cdotson@oyhpt.com.
I love it. Well, Caleb, you've helped us realize our goal of this podcast, which is to educate and empower individuals to take charge of their own health. So thank you for helping us realize our goal today.
Thank you very much. And I love that our goals align.
I love it. So, and listeners and viewers, thank you for tuning in to Health Solutions with Shawn and Janet Needham. We will not see you until next year, Thursday, our midweek podcast, 8 a.m. to 9 a.m. Pacific Standard Time. Thank you for listening.